Okay, here we go. So health insurance. Today we're going to talk about health care in the U.S. We're going to talk about optimal health insurance. And we're also going to get to health care reform, the recently passed health care reform. Are there handouts out there? There's some up here. You're welcome. Okay, so in the U.S., we are the only major industrialized nation that does not guarantee access to health care to all Americans. About 1 in 6 Americans are uninsured. Two-thirds of all Americans get health insurance through their employer. So employment-based health insurance covers 2/3 of Americans, and the remainder, so the remaining 1/6, get health care insurance through either Medicare or Medicaid. So either they're elderly or they're poor, and that's on Medicaid. Notice what I'm talking about here is how we provide health insurance to people. If we were talking about providing health care to people, that would be a system of like clinics or something where we had direct provision. What we talk about when we talk about health care reform is really insurance reform, right? It's about insurance reform. It's about providing health insurance to people. Okay. So in the U.S., healthcare spending is actually much higher than in most other industrialized nations. In fact, the disparities in health spending aren't just across nations, they're even within our country. If we look at average spending rates on different kinds of illnesses across states, even within states across counties, and in some cases even within counties, we see big disparities in healthcare expenditures. There are enormous disparities in spending, and there are also enormous disparities in outcomes. Interestingly, the same amount of spending does not always translate into similar outcomes. So given the same level of high expenditure, sometimes we see very different health outcomes. It's one of the mysteries. Has anyone heard of the Dartmouth Health Atlas? Yeah, I see some nodding. Yeah. Okay, so the Dartmouth Health Atlas is this effort by some professors at Dartmouth to actually take a look at the U.S. and how spending on different illnesses or on average sort of differs by sort of geography. And it's very revealing. Anyone remember the article from the New Yorker about McAllen, Texas, about Atul Gawande? Does anyone remember that from a couple years ago? I'll post it on the website so you guys can take a look at it. It talks about a town in which spending is very high, but outcomes are not very good. Right? So this is one of the big mysteries is we have a lot of spending differences. We also have outcome differences, but they're not really correlated in the way we'd expect. We're not necessarily getting a much better outcomes where we necessarily spend a lot more. Okay. So why don't the uninsured purchase health insurance? Right? This is a question. We've talked about insurance models. We've talked about how all risk-averse individuals would opt to purchase full insurance if they could purchase full insurance at an actuarially fair price. Anyone remember what actuarially fair means again? We'll review. Sorry?
On average, the firms break even.
Exactly. On average, the firms break even. The premium is the product of the sort of the risk of entering the adverse state times the payout in the adverse state. So on average, firms break even. So we've talked about how people would, if individuals are risk averse, they're always best off buying full insurance if they can buy it at the actuarially fair price. We've talked about how people might opt to buy even insurance that's priced at more than actuarially fair if they're sufficiently risk averse. So why don't folks buy insurance? Why isn't everyone insured? David?
They're not being offered actuarially fair prices.
So that's part of it, right? So risk-averse individuals may be unwilling to purchase insurance if it's not available at an actuarially fair price, right? If insurance is being priced at much more than actuarially fair prices, and people aren't so risk-averse they're willing to pay those high premiums, they may choose to not buy insurance. What do we call that? That's a market failure, because the quantity of insurance being purchased is less than less than optimal, less than equilibrium. And that market failure is due to asymmetric information and adverse selection due to that. Exactly. Good. Okay. So other reasons why people might not be insured. Insurers may be unwilling to actually insure some people because they fear the adverse selection, right? The insurance company doesn't feel like it has a good idea of what the risks or the spending risks of this group are, so they opt to just bar coverage, right? We saw some of these issues in the 80s, right? In San Francisco, where sort of single men had trouble getting health insurance in the private market. It was very, very expensive because there was a lot of uncertainty about the expenditures related to HIV contraction. And that was a time where it was very uncertain. Insurance companies were fearful, and they just refused to cover some people, large groups of people, in fact. Third, individuals may be rationally foregoing insurance. So we've had this issue before. Am I not right that we've had this issue with the slides? Yeah. I don't know what's wrong with it. Okay, I'm just going to try to keep a hand, like maybe if I move the mouse every now and then it'll work out. Okay, so the third reason is that individuals may be rationally foregoing insurance purchase, right? Think of, when you think of this option, when you think of this kind of person, think of a young, sort of invincible person, right? Who thinks that no health ill will befall them. And so they don't find it to be sort of worth their while to buy health insurance. And also, they know to some degree, if they get hit by a bus and they're taken to an ER, even if they're not insured, the hospital does have to provide them emergency care, right? So they always have access to sort of ultra urgent care they'll have access to. So they may be sort of rationally foregoing insurance because they have other needs for their dollars at this point in time, right? It could be rent, it could be food, it could be other sort of consumption goods, but they're in their minds rationally foregoing insurance purchase. Fourth, they could simply not be able to afford insurance, right? We in economics talk about people moving consumption around from period to period through borrowing and saving as if this is fairly accessible to everyone. But we know that sort of not everyone can sort of smooth consumption effectively, and people in certain parts of their lives may simply be unable to afford their health insurance premiums. And finally, this is the paternalism. This is the argument that paternalism in this market is based on, that we may suspect that some individuals are not rationally valuing health insurance at what they should, that they sort of cognitively can't sort of get their minds around what insurance is really buying them. They don't see it in the future. They don't see it in the current period, and it's sort of it's not clear to them what insurance was giving them, and so they forego insurance purchases. Okay, so that's why people aren't buying insurance. Why do we care that people aren't buying insurance, right? I mean, for me as an economist, be teaching you about caring, it's first of all funny, but second, this is let's go through the first two arguments, which are mostly economics. So why do we care about the uninsured? First of all, it's the negative health externalities of people being uninsured, right? So if a person, with the outbreak of, say, avian flu, if a person's uninsured, and so they're sort of not necessarily seeking medical care to determine what illness they have, they could really be inflicting a negative externality on the rest of society by not determining, because they don't know that they're carrying avian flu and walking around, right? That's a negative externality that the uninsured may be inflicting on the rest of us through health externalities. There's also the financial externality that the uninsured impose on the insured. So when an invincible young American does get hit by that bus, right, and they show up at the ER needing very expensive care, the hospital will go after them to pay their bills, right? But if this person can't pay and they're not insured, where's the hospital going to turn to recoup those losses? People who are insured to come in, right? The fact that the hospital has to provide sort of care to the uninsured who can't then pay their bills requires the hospital or allows the hospital to sort of charge everyone else a little bit more to cover their losses. So there's a financial externality from individuals lacking health insurance. Finally, there's paternalism and equity motivations. You might have some notion that people are sort of entitled to some basic kind of health care, and through some sense of equity, you feel that people should have health care insurance, so we care when people are uninsured. And simply paternalism, that you just feel like people aren't making good decisions for themselves, and you want to help them make better decisions about their health care access than they're making themselves. Why? Okay, so in the U.S., I said 1 in 6 Americans is uninsured, but another sixth of the population is insured through either Medicaid or Medicare. But 2/3, right, the vast majority of Americans get their health insurance where they get their paychecks. They get it at work, right? So what are sort of the reasons employers provide health insurance, right? It's if you think about it, kind of odd, right? Why would your employer be sort of your source of health care coverage? Well, first of all, employment actually provides a fairly attractive, large risk pool, or just a pooling mechanism. Because, first of all, large groups of people work together, and they work at a firm not because they all share the same illness, right? It's not like everyone who works at, Stop and Shop has diabetes, right? It's not like people are pooling based on health risks. It's sort of a grouping of people, a pooling of people who have fairly uncorrelated health risks, and they're large pools, right? The largest of the pool helps to keep administrative costs low. Because you could think that there are sort of some basic fixed costs to running a health insurance system, right? Sort of having the staff to sort of collect the premiums and pay out the claims. And that each additional person covered by that system does increase costs, but a lot of the costs are sort of fixed costs, one-time costs. So when you're taking that administrative burden of having your health insurance system and dividing it among your very large number of employees, the administrative cost per capita becomes very low, if you're using a big employer, sort of as your pooling mechanism. So the amount that premiums have to be higher than the actuarially fair price just to cover the administrative cost of running the health insurance program is small if you have a big pool of people, right? So one reason insurance premiums may be higher than actuarially fair prices might be administrative costs. We call it sort of administrative load. Other reasons may be sort of non-competitive pricing of policies, right? That's a different story. But this part of the administrative costs can be minimized per insuree if we're pooling a large number of insurees into the risk pool. Finally, employers provide health insurance because it's a tax-advantaged form of compensation. So you work for your employer, you provide a certain amount of labor supply. He needs to compensate you for that labor supply, right? He can do so in wages, but he can also do so through in-kind benefits. All of these benefits, whether those in-kind benefits are child care at work, or health insurance, or participation in a pension program, or your salary, all of this compensation can be deducted from sales when the corporation determines net income, right? And it's taxed on its net income. So all of these compensation expenses are tax deductible at the employer level. But when you get wage income, what do you then owe to the government? Individual income taxes, right? But we do not tax individuals on their in-kind benefits. When you get health insurance coverage from your employer, you don't then write a check to the government for that piece of your compensation. So when your employer offers you health insurance rather than additional wages, it's a sort of tax-efficient way for him to compensate you for your labor supply. So part of it's a tax story. Finally, it's also a historical accident and sort of the inertia from that accident. So part of the reason employers offer health insurance is there was a time during World War II when price and wage controls were in place that sort of employers could not compete for better workers by increasing pay because there were wage caps. So employers had to come up with other ways to attract the very best workers. And one of the things they started offering was health insurance coverage. And so we started off with an employment-based system, and don't fix it if it's broken kind of reasoning has left us today with an employment-based health insurance system in the US. So we've talked about some of the reasons why we have an employment-based health insurance system in the US. What are some disadvantages associated with having job-based health insurance coverage? One of them is what we call job lock. So we've already talked about the lock-in effect on capital gains, right? This is job lock. In economics, if the word lock is in it, it's probably a bad thing. It's a bad thing here. So job lock is the idea that individuals are reluctant to change jobs because their health insurance is job-based. So for example, if you were working for a large employer that provided you with health insurance, you may be reluctant to join a startup where your skills may be actually best used if that startup does not offer you health insurance, because you get access to this risk pool through your employer. So job lock is sort of the reluctance to change jobs due to employment-based health insurance. And it can lead to an inefficient match between workers and jobs. Individuals may not be working in their most efficient capacity because of health insurance. Cross-sectional analysis, when I say cross-sectional, what face do you all make? Squinty, right? Because cross-sectional evidence is so-so, right? So cross-sectional evidence suggests that individuals with employer-provided health insurance are less likely to change jobs. So you're all squinting at me, right? I said cross-sectional. Because why is this not good evidence? Well, people may be selecting into jobs with and without health insurance based on their individual characteristics, right? You can imagine someone who's coming out of school and is choosing between employers. If they're more risk-averse, they're going to choose the job that offers health insurance. Because they're risk-averse, they may be less likely to want to change jobs inherently, right? So comparing people in jobs that offer health insurance to people in jobs who don't offer health insurance is making a comparison across people who differ in more ways than just the fact that they have health insurance through their jobs, right? It's the problem with all cross-sectional regression. There's also this sort of general fact that jobs that offer health insurance tend to be sort of better jobs. Right? They tend to be at more stable firms. They tend to have firms that are sort of doing better in the market and have more job security. You're much likely to have to change jobs for job-based reasons, right? Because your company is deteriorating. There tend to be better jobs. And so there's sort of a selection in sort of what the job type that comes with health insurance is as well. There are some quasi-experimental papers that look at actually the expansion of what's called COBRA coverage. So COBRA coverage was something that was created in the 90s, I believe. What it gives you is access to your former employer's risk pool for a fixed amount of time, maybe roughly a year, maybe 18 months, I can't quite remember. So for a fixed period of time after leaving your job, you have access to your former employer's risk pool. So you can buy into their health insurance system, but you have to pay typically both parts of it, the employer and the employee part of the premium. So COBRA gives you a right to buy into that pool. States expanded COBRA coverage in the 90s, and when we see state-by-time variation, right, we see economists running regressions. And so these quasi-experiments are used to sort of assess the impact of health insurance coverage on job lock, right? And those studies concluded that roughly 25% of the job lock reduces labor mobility by roughly 25%. So you're 25% less likely to choose and switch to a better job for you due to job lock. That's what these empirical studies suggest. So job lock is a non-trivial sort of drag on the sort of matching of workers and jobs. So other disadvantages of an employer-based health insurance system. Well, I touted these advantages initially, right? And those advantages were largely driven from the fact that employment is often a big pool that you get to be part of, right? A big pool has a bunch of people who have uncorrelated risks. It's sort of like portfolio diversification, right? It's the fact that you're one little risk in a big pool of risks, and the administrative costs are low because you're in a big pool of people. What if your pool isn't so big, right? What if you work for a small business? So employment-based health insurance coverage, one of the disadvantages of it is that it really sort of particularly hurts small businesses. So small businesses have unpredictable insurance costs, right? Why is that? When your pool gets big, right, something known as the law of large numbers kicks in, and the predictability of expenditures out of that pool becomes far more predictable. Think of it this way. If your firm had 5 employees, there's some chance that 2 out of 5 of you could have a heart attack in the same year, right? There's a very small chance that 40% of Citigroup's employees are going to have a heart attack in a given year. Well, maybe some years. Kidding. No, your risks are generally pretty uncorrelated in a big firm. In a small firm, there's just sort of idiosyncratic risk is higher. So in a small firm, insurance costs are less predictable, and you're going to have higher administrative costs, right? Because you're dividing those fixed costs. You need at least one person running your system, right? You're dividing that administrative cost over fewer people, and you're going to have higher administrative loads per capita. So in fact, we see sort of differential offering by firm size. So by offer rate, I mean, does your firm offer you the option to buy health insurance, right, to participate in health insurance? With 98% of firms with more than 25 employees, or with 25 or more employees, offer their employees health insurance. That offer rate falls to only 72% for firms with 10 to 24 employees. If your firm has less than 10 employees, you have a less than 50% chance of being offered health insurance. So as we can see, firm size is a big determinant of whether or not a firm offers its employees health insurance coverage. Question?
Isn't there also the issue of take-up rate? So even if your firm offers
Yes.
health insurance, if you have access to premium, like health insurance policies that are, cost more, then you have more cost sharing shifted towards the employees. So even if you offer it, they might not be able to financially be able to take up that.
That's a great point, because what I said is offer rates, right? For all the reasons described above, premiums tend to have higher load factors, right, because of idiosyncrasies of risk, greater adverse selection because of the small pool, and higher administrative costs. Premiums are much higher for small businesses than they are for larger businesses. And so even if, first of all, you have a lower offer rate, you likely have a lower take-up rate because of the load. The difference between the policy you're offered and the actuarially fair price for insurance for you is likely to be much bigger at a small insurance company. Because adverse selection is worse, right? Because if you think about it, Citigroup's going to offer its employees insurance because it's part of what it does, right? If you show up at Citigroup and you take up health insurance, it's not the degree of adverse selection is not large. At a small business, the fact that your small business is even trying to offer health insurance makes the reinsurer, right, the insurance company covering the small business, concerned that someone at your firm has a real medical problem, and that's why your tiny firm is lining up to buy health insurance, right? Because just to talk about how insurance markets work, so suppose I had a small business, I had 5 employees, that I wouldn't run my own insurance scheme, right? I would go contract with United Healthcare or with Blue Cross Blue Shield, and they would offer my employees coverage for some set of premiums, right? That would take the adverse selection risk and the administrative cost and all of these things into account, right? They would insure my employees. Really big firms actually tend to self-insure. So a really big firm isn't actually going out to United Healthcare and pushing the risk onto the insurance company. They're actually self-insuring. They're taking in premiums and they're paying out claims. Their employees might have a United Healthcare card because United Healthcare administers their program for them, but the risk of sort of the insurer risk is actually with your firm. It's often with your firm. I know MIT self-insures. I'm not sure about NYU, but given its size, I would suspect that it does as well. It's just sort of one less margin to be paying to an insurance company. So you have an insurance card. Like if you work for a very large firm, they're probably not carrying the insurance risk. Your company is actually probably carrying it. Okay, great point. Thank you. So part of what the recently enacted healthcare reform was trying to do, so it has many parts, right, as we know, it's a big complex piece of legislation, but one part of that, of the ACA, as it's known by other names too, but let's call it the ACA, let's call it by its legislative acronym. So one part of the ACA is about helping small businesses participate in the health insurance market. For all the reasons we talked about, we often call it the individual market, even though they're small businesses, you're basically individuals, right? You're such small pools, tend to have very high premiums because of the administrative costs, because of the adverse selection issue, because of the idiosyncratic risk. So part of what ACA did is sort of try to help small businesses band together into bigger risk pools, so they can take advantage of some of the benefits that larger firms enjoy. We'll talk more about that in a second. So by 2014, the way in which I said, the ACA is trying to help small businesses sort of pool together like big firms do, right? So they can sort of together form a risk pool the size of a large firm. So by 2014, states have to set up what's known as SHOPs. So Small Business Health Options Programs, or SHOP exchanges. Think of the SHOP exchange as a connector. It connects small businesses together to form bigger risk pools so that the loads on their premiums are smaller, so their premiums go down. So the states have to set them up, and the small business piece of this is also, there's part of it that's mandated, right? So businesses with 50 or more employees, or more than 50 employees, must either offer coverage themselves or pay a penalty of $2,000 a year per full-time worker, but excluding the first 30 workers. So very small businesses are not really affected by this, right? Employers with more than 200 employees must, in fact, default people into health insurance. Those employees can then opt out of health insurance, but they must be defaulted into the health insurance program. And if the employee chooses to opt out of the health insurance program at a large firm, he or she must then pay an individual penalty. This is the piece that we call the individual mandate, right? Because you either participate in your firm's big health insurance program, or you pay a penalty. Very small, low-wage firms will be subsidized through tax credits to help them offer their employees health insurance. So that's sort of the basics of sort of healthcare and health insurance in America. So I've said many times, if there's one thing you take away from this class, I want you to. So this is yet another one thing I want you to take away from this class, right? So there's probably 5 or 6 of them by this point. So for the rest of your lives, I want you to know right away which one is Medicare and which one is Medicaid. And once you're part of this crowd, you'll realize how many people goof it up all the time. Your elected officials, policymakers, cable news, they get it wrong all the time. Medicare is old people. Medicaid is poor people. There are people who are on both. They are poor old people, right? Right. So Medicare is old people, Medicaid is poor people. There are people on Medicare who are on disability insurance. They're a special group. We'll talk about some other special groups in a second, but by and large, that's the difference, right? So you'll hear some senators get up and say, we got to protect Medicaid for our retirees. That guy is wrong, right? Sure, you want to protect Medicaid for that small portion of the retired community that does receive Medicaid services, but he really means Medicare, right? Okay, cool. So let's talk about these 2 programs. So we're going to talk about who's eligible for the program. One second, I'll get your question just a second. Who's eligible for the program, what premiums they might owe, what deductibles or co-payments they might owe, and what services are excluded from the insurance form. Okay, so let's first talk about Medicaid. Medicaid covers families on welfare, families on TANF, families receiving cash welfare from the government. It also includes low-income children and pregnant women who may not be on TANF, and low-income elderly individuals who may be disabled. So those are all the Medicaid groups. So Medicaid is a program run by the states with federal support. The federal government subsidizes a fraction of every dollar the state spends on Medicaid. We'll talk much more about this when we talk about state and local public finance at the end of the semester. But so that's the basic idea. The federal government supports it. States get to spend some of their own money and provide health insurance for folks in their state. Some states are, states are differentially generous when it comes to Medicaid coverage. I think New Jersey, it's up to 300 or 400% of the federal poverty line. Your kids can be covered by Medicaid. It's called S-CHIP. People have heard of the term S-CHIP, the State Children's Health Insurance Program. So in states like New Jersey, it's a large percentage, or it's multiple times the federal poverty level. In other states, it's less generous, right? It might be up to 120% your kids can be covered. Part of the reason there's a lot of variability in sort of how many, at what level of the federal poverty line you can still be eligible is that there's vast differences across states in sort of basic cost of living differences, right? Alabama and New Jersey have very different cost of living levels. And so there's differences across states in sort of eligibility. There's also just sort of different tastes for redistribution across states as well. So both of those things determine eligibility. So what premiums do people owe on Medicaid? Nothing. You don't pay a premium as part of, for your health insurance through Medicaid. Deductibles and copayments are basically none, but they can be very small in some states for adults covered through Medicaid. A lot of the expansion we've seen in Medicaid is about covering children and pregnant women. It's about giving sort of young children and women-bearing children access to sort of basic health care. We've seen a big expansion in those services. The services excluded are minor. There's some controversy about dental for children with Medicaid. But so when you look down this column, when you look at sort of how this insurance scheme works, it's actually pretty generous coverage, right? You're paying virtually nothing for health insurance. But why is Medicaid not awesome if you're a Medicaid recipient? While you don't pay much for the services, it's actually difficult to access the services because the reimbursement rates of the Medicaid program to physicians is low. And so as a physician, you're not always the most excited, right, to see Medicaid patients because you know the federal government or the state government's reimbursement rate is fairly low. So part of the problem with Medicaid is there's a lot of queuing. It's hard to get access to a physician. And that's why we see sort of, I talked about if we were in the business, if the government was in the business of providing health care and not health insurance, what we'd see a lot of is sort of government clinics everywhere, right? And even though we're not in the business of providing care, a lot of Medicaid eligible populations do rely on sort of clinic or center-based care because that's a source of access that sort of regular private practice physicians don't always offer. Right? Because often these clinics or centers are partly supported by grants, from the state or from foundations or from charitable groups, from religious organizations, and that helps cover the cost, right? And so people who are on Medicaid can get access. There's sort of when you subsidize something, you're going to increase the quantity supplied, right? And that's how sort of people on Medicaid can get access sometimes, because it can be hard. It can be hard to find a physician who's actually willing to take Medicaid-based insurance. So generous coverage, hard to use. Now let's look at Medicare. So who is eligible for Medicare? Retirees and their spouses 65 years and older. Certain disabled individuals under 65. So we'll talk more about DI next time, but I think I've mentioned before that if you're deemed sort of disabled enough to go onto disability insurance, it'll actually be a couple years until you're eligible for Medicare. And that seems kind of crazy, right? Someone who's deemed so injured they can't work anymore is not eligible for government-based health care, even though they're not working, and most of health insurance in America is through your employer. And that's simply because it's really expensive. It's, there was a time in the 90s, there was an effort to sort of close the gap and offer people Medicare coverage soon after they got into DI, but the budgetary expense of it was too much, and they couldn't find the offsets for it. So even now, you have to wait a couple years after you go into DI in order to be eligible for Medicare. So certain individuals who are disabled under the age of 65, and people with kidney failure, actually, is an interesting group. They're also eligible for Medicare, whether they're on dialysis or they need a transplant, partly because it's such a chronic, long-term, very expensive type of medical need. Okay, so what are premiums? For hospital coverage, there's no premium. You've heard about Medicare Part A, Medicare Part B, Medicare Part C, Part D. That's what the stuff is about. So the hospital piece has no premium. Physician coverage costs roughly $67 a month. That's seeing your doctor. Prescription drug coverage is variable because it was run through private insurance companies. Remember, if you guys I don't know if any of you have parents or relatives who are in this age group, or you remember the news coverage of folks having to choose their Medicare Part D provider, right? That is choose an insurance company. Because there's variability across insurance companies, exactly how the program works, the premiums vary for drug coverage. When you think of when it comes to deductibles and co-payments, Hospital coverage, you have roughly a $1,100 deductible for the first 60 days you're hospitalized. Physician coverage is a $135 deductible and 20% coinsurance. Coinsurance just means whatever it costs, you're sort of liable for a fifth of it. And prescription drug coverage just varies across insurance provider, what your sort of deductible and copayment is. The service is excluded. So prescription drugs were excluded until 2006. It was sort of a perennial issue when it came to Medicare, is why aren't drugs covered? Now they're covered. Other services excluded actually include routine checkups. Dental care is not covered. Nursing home care is not covered, which is sort of a continuing concern for some individuals. Eyeglasses and hearing aids are not covered by Medicare, and immunization shots are not covered by Medicare. Okay, so what have we learned about Medicaid and Medicare? That's what we're going to turn to next. So in the 90s, as I said, as S-CHIP was rolled out and other parts of Medicaid were expanded, the states expanded Medicaid at different points in time, state-by-time variation, opportunity for regression, and we saw empirical studies come out of this time period. One of the interesting things that we learned is that only roughly 1 in 4 newly eligible individuals actually took up Medicaid. That's really interesting, right? 3 out of 4 people who are eligible to take up Medicaid didn't do so. Naturally we ask why, right? This is a benefit you're entitled to, and you're not actually using it. Well, first of all, it might be information difficulties. People may not realize that they're eligible for Medicaid. Second, there's stigma. People might feel badly about using state assistance for medical care for themselves or their children. And second, and finally, private insurance. We've talked about Medicaid. It's not always easy to access care, and it's geographically, it varies across different parts of the country how easy it is to use your Medicaid insurance. So you could imagine if you're eligible for Medicaid, you might not choose to switch from your private insurance to Medicaid because of the difficulty of access, right? So private insurance is part of it too. How many of you are interested in health issues, sort of, for like post-school? Some of you, yeah. So for those of you who are interested in the provision of public services, I think a really interesting aspect of take-up is that there are these real differences across racial and ethnic groups in take-up rates. And sort of, if you're in the business of providing public services, it's sort of an interesting access issue, right? That there's sort of just different and persistent differences across racial and ethnic groups when it comes to take-up of some of these programs. We saw with these expansions of Medicaid in the 90s that there was some crowd out. In fact, there was substantial crowd out. Roughly 20 to 50% of individuals who switched onto Medicaid did so dropping private insurance. So they moved people from private insurance into Medicaid as we expanded Medicaid. There were big increases in utilization. Early prenatal care and preventative visits by children in particular increased a lot, by roughly 50%. And this increase in utilization did come with big health improvements for Medicaid. So we saw infant mortality drop by nearly 9% as a result of the Medicaid expansions. These improvements are actually considered cost-effective. Each infant life saved costs roughly, on average, $1 million. Given a value of a statistical life of roughly $7 to $8 million, maybe $9 million, this is clearly a cost that was well worth undertaking. There's a question up front. And then Matt, Vasundra, and then Matt. It was answered? Okay, great. Matt?
I can't give an example
okay.
off the top of my head, but I filled out applications before that asked, have you received an entitlement or have you
really like
a state program?
For stuff like something that has nothing to do with the government,
A job.
like a job
Yeah,
or something, whatever. Yeah.
Exactly. Well, it could have been for my last job, which was a government job. I can't give a good example.
So
But can you be disqualified for certain tax credits or something if you're using like an entitlement?
Yeah, there are these triggers. Do you remember when we did budget constraints and we were like, oh, this thing goes away. You lose your Medicaid eligibility if you get off welfare.
Yeah.
There are other cliffs like that too.
So could that be a reason people?
Yeah, people may not, that could be part of it, that they're losing other benefits, especially maybe at the state level. There might be some state differences. Program interaction is an interesting question, and we have to look at it. Also, part of it could be why that question is asked. I'm just sort of thinking off the top of my head. It could also be that you could imagine an employer is asking you if you're potentially Medicaid eligible. so they could transfer you onto Medicaid and not have to pay part of your insurance costs on the employer side. Not you in particular, but any employee, right? Like if that's possible, they might be looking to do that too, which I'm not sure, but it could be. It's an interesting question. I'm not sure if they're allowed to discriminate too in some way, but that's interesting. It's very interesting. Okay, this was our magic forwarding. Okay, so we've talked about Medicaid. We'll talk more about Medicare towards the end of the lecture. But first, let's talk about optimal health insurance. So when we think about insurance schemes, right, the benefit of insurance is the fact that it allows you consumption smoothing benefits. You can smooth consumption across states of the world. That's the benefit of insurance. The cost of insurance is the moral hazard behavior it triggers. Remember, moral hazard is sort of the behavioral changes you make because you're insured, right? So that's the cost of insurance. The benefit is consumption smoothing, the cost is moral hazard. We weigh them against each other, and sort of the optimal insurance scheme is going to offer sort of full coverage for really expensive healthcare costs that you can't possibly consumption smooth on your own, right? But not offer as generous coverage for moderate amounts of spending that you can consumption smooth on your own. And the reason it's not going to offer as generous coverage for that initial spending is to sort of reduce the sphere of moral hazard, right? Where moral hazard can be sort of particularly bad. So the trade-off between consumption smoothing and moral hazard is going to suggest that individuals should bear a large share of the medical costs within some affordable range, right, that they can consumption smooth on their own for, and that they should be fully insured when costs become unaffordable. Unpredictable catastrophic costs should be fully insured, something like a heart attack, right? Something like getting hit by a bus. That should be fully insured. Predictable minor costs, like annual checkups, should be paid for by the patient. Because first dollar coverage, i.e. the very first dollar you spend on medical care, yields minimum consumption smoothing benefits, right? You can probably save enough to pay for your annual visit to your doctor, right? That's consumption smoothing you can do, but you can generate substantial moral hazard effects here, right? The caveat to this, right, is that if there are, sort of the fact that you're paying your first dollar for your doctor visits, right, might lead you to not go to the doctor when you should, and it could make you more likely to actually experience the risks of catastrophic illness. A lot of what we call preventative care, right, it's often talked about, especially in the political realm, like, oh, if we just gave people more preventative care, we could save a lot of money on the catastrophic stuff that happens to them. I was talking to a friend of mine who's an actual health economist, not like me who plays one in lecture, but she's an actual health economist, and shockingly, very few preventative care type measures are cost effective. And the reason, because the way to think of it is sort of, for the person who one day develops severe diabetes and has to have their foot amputated, the preventative care of diagnosing them as diabetic early and giving them the medication, the testing equipment, all that, is well worth it for them. But on the day they show up as sort of kind of having diabetes, when you have no idea that they'll end up as the person who gets their foot amputated, they're not distinguishable from a lot of people who look a lot like them. And so you end up providing the preventative care to many, many people, most of them who will never incur or never would have incurred the catastrophic care expenses. And so while we're preventing foot amputations, yes, in terms of just sheer dollars spent on health care, it doesn't work out in monetary terms. That the amount of spending you undertake to give everyone the preventative care ends up being more than sort of the really intense care the few that would have entered that terrible state would need. So there are reasons to want people healthier and not having their feet amputated besides medical care spending. But if that's the only thing we're looking at, not most things that people talk about as preventative care don't work out in dollar terms. Like if we're looking to save money on Medicare, right, on what we spend on Medicare, preventative care would not save us money on Medicare. We might make people healthier, and the increase in their quality of life is certainly worth something, right? And there are ways to talk about that. But in terms of what we spend on healthcare, there aren't a lot of preventative measures that actually save us money in the end, it turns out.
There's like definitive empirical evidence that it just doesn't work.
I mean, there are some kinds, and I can look them up, and I can tell you about them next time. But by and large, right? Because most people just don't. Most people who are in the risk group that we would give the preventative care to never would have entered the costly state. Yes, David.
I mean, if people are getting healthier because if they're staying healthier because of preventative care, then
That's
I would think that they are, by virtue of being healthier and healthier for longer, that they're staving
So some of those things are factored in, right? The fact that, if you're staying healthier to prevent diabetes, you're also less likely to have heart disease. That's what I think you're talking about. Something, people who run these studies are smart people, and I trust they're taking that stuff into account. The part of it that is harder to quantify, and I suspect is not in it, that you're a more productive worker if you're healthier, right? You might be productive for a larger number of years. If you're a more productive worker, maybe you invest differently in your human capital, right? You might continue to sort of train and intensify your skill set. So there are sort of other dimensions of this that are harder to quantify and I suspect would not be in this calculus, but a lot, I'm sure they're thinking about all the things that would be prevented by a health program, preventive health measure. But I can, I'll look more carefully into it and I can get back to you about it. Basundra.
Can it be an example of positive externality?
Why is it an externality?
Because when people are getting preventive health care, spread of any disease.
Okay, so if there's something like, so that would be something that, it's a very good point. So I said, Medicare doesn't cover any immunizations, right? We might want old people getting their flu shots because they're exposing the rest of us to the flu too. Yes, that would be a reason that's another caveat. So it's preventative care and also the positive externalities from people getting the basic medical care that could lead to negative health externalities to the rest of us if they didn't get it. Absolutely, it's a very good point. Other questions? Okay, wouldn't it be nice if lecture was always like this? Like we just chat, hang out, yeah. Okay, so one example, so this is a famous example of maybe non-optimal health insurance design, right? A health insurance program that's not optimally designed. So what did I say how would you want to structure it? You'd want to offer low levels of coverage for initial spending, but as spending got really high, you'd want to cover more and more of that spending, right? So that if someone is incurring very, very large medical costs, all of that is covered, right? Because it's very hard for them to individually consumption smooth the cost of a very expensive cancer treatment, for example. Okay, let's look at Medicare Part D, the prescription drug coverage that was introduced in 2006. So the donut hole is a famous part of this sort of scheme's design. So let me explain what the donut hole is. So in Medicare Part D, originally, the way drug coverage worked is that your first $250 of drug spending each year, you were on your own. You had to shell that out yourself. 75% of the next $2,250 would be covered. So you'd be liable for 25% of spending between $250 and $2,500. Then, after you hit $2,500, the next $3,600 of spending was not covered at all. Zero coverage, zero insurance. That, you're on your own. And then once you got to the $5,100 amount, 95% of your expenses were covered. Okay, so that looks like no coverage, lots of coverage, zero coverage, lots of coverage. It's very hard to come up with a function, a moral hazard function that this is sort of trying to optimize against, right? That's a very unusual pattern of moral hazard if this thing is optimal. We suspect this thing is not optimal, right, when we look at it. That donut hole is offering people zero consumption smoothing for spending between $3,600 and $5,100 a year on drugs, on medical drugs. And so this was created, it turns out this donut hole and the way this was structured was about, there was a sort of a spending amount that Congress wanted to sort of come in under for this piece of legislation. And, there were limits, right? And they could play with certain levers, but it looked like, they needed to sort of adjust the way they were subsidizing drug coverage in order to meet that target. And so, if you look at it, you can kind of have it make sense, right? If you're a really constrained legislator, you're like, okay, initial coverage, initial spending, no coverage, they're going to carry the first $250. But a lot of people, between $250 and $2,500, that's a lot of money if people are spending on drugs. Let's cover a bunch of the next stuff, because that's like, where we want insurance to kick in. And then when people are spending tons of money per year on drugs, worth $5,100 a year, that's people who are really, really sick, and their drug spending could be really high. So let's cover a lot of that stuff. But in between, we need to save some money somewhere, we're going to just not cover this stuff. And hopefully there aren't a lot of voters in that group, right? Right. So this is the way it sort of worked out. It's called the donut hole. It's interesting. It's suboptimal because it doesn't have this pattern of low coverage for initial amounts and higher coverage for higher amounts. Okay. This is the graph of this lecture. This is the only graph, the only model you need to learn. Yes. Okay, so let's go through it. So we have so this is the market for doctor's visits This is something where we think there could be moral hazard, right? No one is talking about, if I had a hypothetical child and he or she broke his or her arm, I probably wouldn't be, as long as no one is trying to charge me $100,000 for a doctor's visit, I'd probably just take my kid to the doctor, right, if he broke his arm. That's not the part that's not the kind of demand we're talking about here, right? We're talking about maybe I've hurt my knee playing some sport over the weekend, and it kind of hurts. If a doctor's visit is $50, I'd go to the doctor and get my knee checked out. If the doctor's visit is $500, I might wait a little longer and make sure I'm really hurt and it's not going away on its own, right? That's the kind of demand. There's some elasticity here, right? Because for something like, my loved one has had a heart attack, what does my demand for medical care look like? Really steep, right? Price doesn't matter that much. I'm going to get coverage. We're talking about something that has some elasticity to it. So we're not talking about, there's the kind of medical coverage, medical care you're going to get if you're being rushed to the hospital in an ambulance. That's not a particularly elastic part of the demand curve, right? We're talking about elastic types of medical care. So this is like a doctor's visit, like a doctor's visit for something that's happened to you that maybe you could choose to not see a doctor for. Okay, demand curve is downward sloping, like all demand curves. My private marginal cost is this red line. Let's take my life as an example. So I have insurance through NYU. When I go to see my doctor, I pay my copay. Right, that's the part so when I decide whether or not to go see my doctor, I weigh the benefits of seeing my doctor against the $30 or $35 copay I have to see my doctor. So my cost of a doctor's visit is flat. It doesn't really change. It's always $30 or $35, whatever it is. It's the same private marginal cost for every doctor's visit I have. But does my doctor just charge NYU? Is that all he charges? No, my Manhattan doctor probably costs $220 or something to see, right? It's Manhattan, it's expensive. Who does he bill the rest of that to? My insurance company, right? Probably NYU. So the social cost of that doctor's visit is much higher than the copay I faced. You can think of the blue line, it says 100, but you can think of that as, this is a doctor not in New York, apparently. So doctor's visit is $100, you only pay a $10 copay, right? So when I decide whether or not to see my doctor, I think of my copay and weigh that against how much I value seeing my doctor. My demand curve tells me how much I value seeing my doctor. Right? I look at that. I look at my marginal cost, and I find equilibrium and determine how many doctor's visits I'm going to have this year. The social marginal cost is much higher than my private marginal cost, and so I overconsume medical care relative to the social optimum. I, on average, am probably paying for those extra doctor's visits, right? Because my premium is adjusted to some degree. If everyone in America starts seeing the doctor more, what happens to everyone's premiums? They go up, right? But the way insurance works is the premium is a sunk cost. There's some effect of me seeing the doctor more on my premium, but it's pretty weak, and it's certainly in the past. When I wake up tomorrow and my knee kind of hurts, my premium is a sunk cost. All I'm thinking about is marginal cost. And the only marginal cost I face of seeing my doctor is the cost of my visit, the copay. There's other costs, right? There's the fact I have to skip some work. I may hate going to the doctor, right? I could also catch some foul disease from someone at my doctor's office, right? There are other costs, but in terms of money, it's just the copay. So I overconsume doctor's visits relative to the social equilibrium, which is point A. I'll consume at point C, the social equilibrium is point A. Any questions about this? Pretty straightforward? Okay, good. Okay, so consumption beyond the efficient level is a form of moral hazard, right? I'm consuming doctor's visits differently because I'm insured. The cost of the increased consumption for moral hazard isn't free. It isn't free to anyone. The premiums will be adjusted in the future to cover my overconsumption. And when you think of the social cost, we think of the doctor charging $100 for this visit. That's the cost of his time. It's the cost of, the tongue depressors and the equipment he uses, right? All of those costs have social value, right? My doctor could be enjoying leisure. He could be playing with his kids. He could be doing various other things. And so that's what the cost comes from. The social cost is the cost of him providing that doctor's visit to me when I value it at much less than what it costs society to provide it to me. The deadweight loss depends on the elasticities of supply and demand. Demand for healthcare, and so the other part of this moral hazard, right, is so I am overseeing my doctor. I'm in there every week, right, because of my health insurance coverage. What is that doing to everyone else's premiums eventually? Going up. What's going to happen to coverage? Some people are not going to be able to afford their premiums, right? And we know that's because they just can't afford to pay for it. And we also know that the low risk type as the premiums go up for the group, within that pool of people, the lowest risk types, the insurance is getting to be less and less actuarially fair for them, right? It's getting to be more and more expensive. More and more low risk types will opt out of insurance, and we'll have a market failure, right? There'll be underinsurance of some folks, either because they can't afford the premiums, or the premiums just are too expensive for what their sort of expected medical costs are. So, okay, so I said that the degree of dead weight loss, right, associated with health insurance. Okay, so I want to back up for 1 second. When I talked about this problem, did I talk about Medicaid or Medicare? No, this is not a problem of government health insurance. This is a problem of insurance. It's the fact that that you're insured is creating this problem. Government programs are susceptible to this problem, but so is private insurance, right? United Healthcare faces this problem. The 2/3 of us that have employment-based insurance face this problem. This is just this is a characteristic of insurance itself. So I said the dead weight loss of insurance, right, due to moral hazard, depends on the relative elasticities of supply and demand. So let's first talk about the elasticity of demand. How much more medical care do I demand because I'm not paying full freight on that unit of medical care? So there was this experiment run by the RAND Corporation, which is like a private research group. They ran this experiment in the 70s, where they randomized people into 3 different groups, and they had differential levels of health insurance coverage. What they found is that medical care demand is in fact price sensitive. Individuals who are in the free care plan used about 1/3 more medical care than those paying 95% of their costs. So that, in a way, it was sort of a radical finding, right? Because there was a world in which people thought, no one overconsumes healthcare. Who likes going to the doctor? You go to the doctor because you're sick. You don't go because it's cheaper. No one is saying that you decide to go to the doctor because it's, there's hypochondriacs, but most people don't go to the doctor because they find it fun. It's the idea that when you weigh the decision to go to the doctor, if you had to pay for the full cost of that visit, you might choose differently. You might choose to see if you get better on your own a little longer, right? That you just sort of would consume differently if you paid full freight. So this experiment was one of the first findings to show that how much you paid for your visits, how much you paid for your medical care changed how much medical care you consumed. They also found that those who used more health care due to the lower price did not on average see significant improvements in their health outcomes. Granted, this was only over a couple years or so, but still we didn't see real improvements in health outcomes from added care. But there is a small group. So for those who are chronically ill and didn't have sufficient income to easily cover their co-payments, so they couldn't see their doctors regularly to treat their chronic illnesses, there was some deterioration in health that they couldn't actually see their doctors, right? So those folks did benefit from seeing their doctors more often if they're chronically ill and they're financially constrained from seeing their doctors. Okay, so we know that there is moral hazard. The RAND experiment told us that price matters. People change their consumption behavior because they're insured. What can we do to mitigate moral hazard when it comes to health insurance? Well, this is true of many kinds of insurance. Well, first of all, we can have deductibles. So your first X dollars of health care, you're fully paying for, right? So if, your first $1,000 of medical care, $500, $300, whatever, you're fully liable for. Relatively high deductible policies are a good way to mitigate moral hazard, right, on the dimensions that people are sort of elastic over, right, while actually providing catastrophic coverage that allows for consumption smoothing over really unaffordable healthcare expenses. We can also have co-insurance or co-payment schemes. So when I want to go to see the doctor, it's not like I pay $0, I at least pay $30, right? Or co-insurance, which might be that, if I want to get a procedure done, I have to pay 15% of the cost. So each dollar that's spent, I'm paying 15 cents of it. That's co-insurance. A high co-insurance rate does reduce moral hazard, of course, because I'm shelling out money for that service, but it also reduces the consumption smoothing benefits, right? So if you had a 15% co-insurance rate for even catastrophic care, that's going to limit your ability to consumption smooth, right? If something is very expensive, like very, very costly cancer treatments, 15% of that could be a really large expense for most Americans. And so if we have co-insurance rates that are sort of uncapped, the amount of consumption smoothing we're offering people is actually limited, right, by the co-insurance. So you can imagine a scheme where you're liable for, maybe everything. You have a deductible of $500, and then you have co-insurance. You have to pay 15% of spending up to $10,000 or something, and then you're fully covered, right? That could be something. That could be a scheme that would sort of have some of the principles of reducing moral hazard, but allowing for full consumption smoothing for very high medical care. Okay. So some things that actually exacerbate moral hazard. So secondary insurance, which is the idea, so we talked about deductibles and copayments and coinsurance, right? So if you look at those expenses, the deductibles, the copayments, the coinsurance, you say, you know what, I'm really risk averse. If I get a cold, I don't want to spend $30. I don't want to have to be liable for the $30. Or more seriously, if I have a major medical concern, I don't want to be liable for 15% of those expenses, right? So what you could do is go out and look for a secondary insurance company to cover your deductible, copayment, coinsurance for your primary insurance policy. You're insuring your sort of piece of your primary insurance. What that does, right, is that secondary insurer is taking, if you go back to this curve, right, that secondary insurance program is basically taking my marginal cost from $10 to 0, right, because they're going to cover the marginal cost of medical care. I'm paying a premium to them at the beginning of the year, but that's sunk cost, right? Each time I go to the doctor, instead of me paying the $10 copay of my primary insurer, I'm going to pay nothing because my secondary insurer will cover it. Where it will happen to my equilibrium, it'll move from C to something to the right of C. Consumption will increase even more. Instead of being at C, I'll be down here. So the secondary insurer is going to have to pay how much for that extra visit? Suppose that's one more extra visit. How much is the secondary insurer going to have to shell out? $10. Who's going to end up paying a lot more because I'm consuming that one more unit? My primary insurer. Right? The guy who's covering the $90 for each visit is going to end up spending a lot more. So secondary insurance exacerbates moral hazard and actually increase costs for primary insurers. So yes, question?
Sorry, but
No, of course.
weren't the primary insurance, weren't they paying $90 under the other scenario as well?
They are, but you're going from consuming, let's say, C, like the number of units corresponding to C, which is Q2. You're going to consume one more unit than Q2, right? So they're going to spend $90 for an additional unit, exactly. So because the secondary insurer only bears a small fraction of the cost of your additional consumption, your primary insurer actually bears most of the costs. So this is a problem with Medigap policies, right? Medigap policies are what retired and Medicare eligible individuals, they go out to a secondary market and seek Medigap coverage, right, to cover the deductibles and premiums and co-payments we talked about. And that increases costs for what? Medicare. The moral hazard triggered by secondary insurance on top of Medicare increases Medicare costs. And that's just because Medicare is your primary insurer, right? Anytime you have a secondary policy, the moral hazard triggered by the secondary policy will increase costs for your primary insurer. Okay, so when we think about people buying extra medical care, right? Okay, so you're consuming more than society would like you to consume. There's dead weight loss. But you know what? If those units, if we were talking about the overconsumption of gummy bears are not necessarily healthy. Let's say the overconsumption, not necessarily healthy, they're not healthy, right? There are very few circumstances in which gummy bears are healthy. So let's think about cars. If you're overconsuming cars, right? Due to non-satiation, we think that you are deriving some utility out of those additional cars, and at least you're getting something out of it, right? But with medical care, we're actually concerned that the overconsumption may not be leading to better health. That even if we're buying you units of health care you don't value at what they cost, right? That's what dead weight loss means. You're consuming units of health care that you don't value at the price that they cost, right? But even if that's true, if at least you're healthier or you're a little healthier for getting that additional care, that's one thing. But we worry, right? The additional consumption may not be tolerable if we're not actually improving health. If we're buying you extra units of health care and you're not getting any healthier. The evidence suggests that the marginal benefit of health care declines pretty sharply. That the marginal benefit curve is, down. It's, maybe it's sort of, we'll talk about it in a second, that it's declining sharply in the amount of care you get. So, initial care is incredibly good for you, makes you much healthier. Eventually, marginal dollars spent on you are not buying you much better health outcomes. So spending initially is very productive, but eventually $1 of additional spending is yielding less than $1 of additional benefits in terms of health. Economists often call this problem the fact that we're practicing flat of the curve medicine. The natural question is, what curve are you talking about, right? So imagine we're talking about a set of axes. On the x-axis is healthcare spending. On the y-axis is health. So initially, imagine the curve is upward sloping. You're getting healthier, we spend more on you, right? And then eventually it's getting concave. It sort of looks like that, right? Like the top of a sideways U. Because we're not getting you much healthier for how much more we're spending on you. The curve is flattening out. It's steeply upward and then it's flattening out. Question, Eric?
Are they basing these health outcomes on sort of utilization or on self-reported health?
So it's sort of like when we spend more on you, are you less likely to die? Are you less likely to be readmitted to the hospital? Are you, yeah. So and there are studies that ask for self-reported health, but generally we look at sort of medical outcomes. Yeah. I mean, people run both kinds of studies, but they have differential sort of effects. They're used for different things. Self-reported health is also useful, right? Because there are dimensions of health that aren't necessarily perceptible very easily, right? And so self-reported health is also useful. But in general, it seems like at some point we're spending and we're not getting much for it in the U.S. There's another question somewhere? Okay, so we've talked about moral hazard on the consumer side. We've talked about the fact that you're insured and your marginal cost is only a fraction of the total social cost of your care leads you to overconsume health care. That's demand-side moral hazard. Now let's talk about supply-side moral hazard. So the moral hazard from healthcare providers. So did I skip a slide? No. Okay. So when we pay providers for healthcare, when I say providers, I mean physicians, like the physician you see when you go to the doctor. I also mean hospitals, and when hospitals are a healthcare provider. So all these providers, there's two ways we can compensate a provider for the care they give you. One way to do it is retrospective reimbursement, right? Where you show up at the hospital and you say, I got chest pain and my arm kind of hurts. And they say, okay, here, first take this aspirin, and then we're going to run all these tests, and then we're going to do this catheter thing. I'm not a doctor. I'm going to run out of things they do to you. So they do some catheter thing, they run some other tests. There's a bunch of stuff they do to you, right? And then they make a list of all the stuff they did to you, and they submit it to your insurance company, which could be a private insurance company, or it could be Medicare or Medicaid. And then your insurer then says, okay, we'll pay. We're going to pay for this stuff and write you a check for what you did to what care you provided to our insurer. We will compensate you, right? That's retrospective reimbursement. You do a bunch of stuff, the insurer pays. There's also prospective. I mean, there might be some haggling, right? With insurance companies, there's generally some haggling that we want to do X, Y, Z. We're going to have to call your insurance company, make sure they cover X, Y, and Z, right? So there's some of that, but that's retrospective reimbursement. The doctor decides care and then is compensated for whatever care he provides, like an itemized list, basically. Then there's what's known as prospective reimbursement, where I walk in and I come in and I say I have some chest pain, my arm hurts, and I'm put into a diagnosis-related group. So stuff that could be wrong with me, right? It's chest pain and pain in the left arm could be a diagnosis. It's a cluster of things that could be wrong with me, and the insurance company is going to compensate the hospital or the ER for the average cost of treating a person with my symptoms. The group of people who come in, they'll probably use age or something in this too, right? Someone who's like my age and comes in with chest pain and an arm a left arm that hurts. What is the average expenditure to treat that person? That's what the hospital is going to get paid. Doesn't matter what they do to me. That's what they're going to get compensated. Prospective reimbursement. So, what is prospective reimbursement trying to prevent? Moral hazard on the supply side, right? This is the problem that suppose you go to see your doctor, not because you have a heart attack, but you're just going to see your doctor and they're trying to do some test for something, right? They might ask you, are you insured? It's a question that some doctors might ask, not because they want to, discriminate against you, but they might offer you choices about your medical care if they know whether or not you're going to pay marginal cost or not, right? They might say, well, this vaccination is covered for you. You should go ahead and get it, right? Why not? Or they might say, well, this vaccine costs $600 for you. Do you want to get it? Right? They're going to present you maybe with different choices based on what they know you're going to pay. No one is nefarious here. No one is talking about some kind of evil medical providers, right? This is simply that they might offer their patients different option sets, knowing that you're going to end up paying marginal cost or not, right? So that's what we call SID, supplier-induced demand. and that exacerbates moral hazard, right? If your doctor says to you, well, no, you've got that great insurance. Don't worry about it. I'm going to send you to the best. Your knee seems kind of, you have this kind of back pain. Why don't we just check it out? Why don't we just run the test anyway, right? That's supplier-induced demand, and it exacerbates moral hazard. No one is talking about your doctor being a bad guy, right, or an evil woman. It's more that they're going to differentially treat you based on what you're going to pay for it, because they think about your welfare as more than just your health. Maybe they're going to think about what you're going to pay for that care. Supply-side cost controls could be better than demand-based cost controls. Because what are the demand-based cost controls again? They're high deductibles and co-insurance and co-payments, right? What is part of the problem with co-insurance and co-payments? You might not go to the doctor, right? And get, if I'm walking around with the sniffles and I really have the plague, it's really good for everyone that I find out that I have the plague, right? Or that I have avian flu. This is what Vasundara was talking about. The negative externality I could be exerting on all of you by not going to the doctor is something we worry about if I'm not getting any subsidy on initial medical care. So actually sort of trying to control cost on the supply side could help with that problem, right? It's going to allow for lower co-insurance rates for customers, right, for consumers rather. And it's going to allow, it's going to mitigate supply-induced demand and the use of high-cost technologies, right? If we sort of limit the way doctors are sort of like, no, the fancy new MRI, it's right here, go use it, right? If we limit that without changing whether or not you go to the doctor, we're going to change what the doctor spends on you, right? That's the idea. So we're not preventing you from showing up and getting the low-cost medical treatment that you really, really need. We're sort of limiting what the right tail of expenditures could look like if we're sort of focusing on the supplier side. We're not preventing you from trying to get basic care, right, by charging you a lot of money for your basic care. We're preventing sort of what the crazy expenditures that could come out of that could be. So what are those cost controls? Well, first of all, there's discounted fee schedules, right? The idea that, if we send you, this is sort of a volume discount. If you're a doctor in our network, we're going to send you a lot of patients. We expect you to charge our insurance company a little less per head because we're sending you so many patients, right? This is a sort of a P times Q discount. Prospective reimbursement we just talked about, so I got a little ahead of myself when I described that. I got very excited. So that's prospective reimbursement, right? That we're going to treat you, we're going to compensate you, dear provider, for the average cost of treating someone with these symptoms. What's a problem with pure prospective systems? So if I walk in with my chest pain and my left arm hurting, and the average cost for treating someone my age with those problems is, let's say, $600, because a lot of people just have they're just a little sick or something, they're not really having a heart attack. So when I walk in and the ER knows they're going to be compensated only $600, are they going to really, is their first initial treatment going to be the fancy schmancy test that I might actually need? Maybe not, right? By and large, maybe yes, but maybe not. Because what we're going to worry about is that when we provide a fixed reimbursement for the medical provider, regardless of what they do to the patient, they might do less to the patient, right? They might be an under provision of care because they're not compensated for marginal care, right? They're getting a fixed amount, whatever between what they spend and what they take in is profit. There's a profit motive to sort of under-provide care. There's also a cream skimming motive, right? So if I walk in with my chest pain and arm hurting, and I also kind of look like I really am having a heart issue, they might try to send me to the neighboring hospital, right? Because they know they're going to only get $600 from me, but I'm going to cost a lot more than $600. They can look at me and tell. They might try to kind of send me elsewhere, right? And treat people who really come in and they've just had, spicy food, right? And you get paid $600 for handing someone a Tums. That's called cream skimming. You're trying to get the cheaper patients because you have a fixed reimbursement. So one way to sort of reduce the problems of prospective reimbursement systems is to have a combination. Have neither a purely retrospective reimbursement system and nor a purely prospective reimbursement system, to kind of mix the two. That maybe you offer a fixed fee for this diagnosis-related group, but if costs go way above that amount, you cover those costs as well. So there's some kind of mixing that can be used. Medicare uses this system, the diagnosis-related groups, and problems with this are known. One is known as DRG creep. So if I come in with my chest pain and my sore arm, I might be upgraded into a more higher reimbursement diagnosis-related group, right? If I don't come in with the arm pain, but I come in with the chest pain, and they're like, so your arm kind of hurts too? And I'm like, yeah, sure, my arm hurts. Maybe it hurts. You think I get DRG creep, where people are shifted into higher reimbursement DRG groups. There's also the problem of substitution to other forms of medical care, where sort of if they know they're getting a fixed reimbursement for treating me, they might try to discharge the patient earlier or shift them to urgent care centers, different kinds of medical care, rather than sort of fully treating the patient. Okay, that was price-based, right? This was about changing how we how we reimburse providers for the care they provide. Other supply-side cost controls are quantity-based. So one of these, the one we're going to talk about is managed care. It's an HMO, right, where your medical care is through a central organization. The way HMOs bring down sort of the quantity, because HMOs are about bringing down the quantity of care, partly, right, is part of it is just selective contracting. This is about bringing down price, too. They say, these doctors are in our network. You're not going to any doctor you want. You're going to go to a doctor in our network, and doctors in our network, we've sort of worked out a lower price, too, right? So we have a limited number of options, and they're part of our network. There's gatekeeper-controlled access to specialists. You can't just go see an orthopedic. You have to see your primary care physician. He has to deem it necessary that you see an orthopedic. He might have to call the insurance company, and then you can go see the expensive orthopedic, right? It's a way of keeping quantity low, of keeping access to sort of very pricey medical care restricted. There's a utilization review of the appropriateness of provider practices. This is where your doctor has to call your insurer and say, I want to run this test, I want to run this, I want to do this procedure, and your insurance company has done some study about the cost benefit of that, and they will either veto or okay that utilization. There's global budgeting, so you can have a spending cap or target on sort of a group of people, what you're going to spend on their health care. There's restrictions on access to high-cost technologies. If your doctor, thinks one treatment may be best for you, your insurance company may push back if it's a very high-cost treatment, right, or technology. And finally, there's salaried employees. And so just having doctors who bill and have incomes. This is like Kaiser Permanente, right? It's more like this, where doctors get paid a flat salary. They go to work. They see patients like they're accountants. You're just like, no one. It's just a salaried job, and you see patients as part of what you do from 9 to 5, from 9 to 8, whatever you work. So salaried employee is the other way this works. So what is the evidence on managed care? So the emergence of managed care has been one of the big transformations in health insurance in America in the last few decades. And what is our evidence on its effects? Well, cross-sectional, everyone make the face, squint at me hard, yeah. Cross-sectional evidence suggests that HMOs are associated with lower spending. That if you're part of an HMO, your healthcare costs are lower on average. These estimates might be biased by selection, of course, right? Because if I know that signing up for an HMO is going to trigger this stuff, less access to specialists, sort of gatekeepers that prevent me from utilizing some medical care, restricted access to high-cost technologies. If I know I'm a really sickly person, am I going to opt into an HMO? No. So part of when we just look at the cross-sectional evidence, the fact that people in HMOs tend to spend less, it could be because they're healthier people. They're not that interested in high-end medical care. That's why they're in an HMO. So what do we need? We need randomization. Who helped us with this? Of course, RAND. RAND randomized individuals into an HMO and a traditional plan. HMO enrollee costs were 72% of the traditional plan's enrollee costs, and this was largely due to lower hospital admissions rates. We don't really know whether the money saved through HMOs is actually due to lower quality care. We don't have evidence on that. So, randomized evidence also suggests that HMOs save money, right? They spend less, mostly through not admitting people to hospitals as much. We don't know what the impact of that sort of reduced amount of hospital admissions is, what the effect of that reduced level of care is on health outcomes. So we know they spend less, even through randomized stuff. We don't know what they get. We don't know what the sacrifices are of spending less. So I want to talk about, this is in your textbook, but this is, I think, an important point. So this is about Medicare and managed care within Medicare. So Medicare, health insurance for mostly old people, right? There was an effort to sort of look at whether Medicare could be more efficiently run by using health maintenance organizations, by using the HMO sort of type scheme. Could we bring down Medicare costs, right? Because why do we worry about Medicare? Because the costs of healthcare are growing rapidly, and if they continue at this pace, Medicare costs will swamp our government budget, right? That's why we worry about costs in medical care. is that it's not, maybe it's the fact that Medicare provides a lot of insurance to old people, so there's a big market for treatments for old people, and so there's just more expensive technologies. There's that part of it, that maybe Medicare is helping to drive up the cost of healthcare. But it's also simply that healthcare costs are going up, and Medicare covers a lot of healthcare, right? That's all. It's part of it. It's not the fact that it's a program. It's the fact that healthcare is getting more expensive, and government's part of that. So we worry a lot about health costs and due to Medicare. So there was an effort to sort of see, maybe HMOs, they do seem to spend less money. Maybe we should try a version of an HMO in Medicare to see how well it works. So it was introduced in the 90s. It's called Medicare Advantage. You're part of an HMO, basically. And these HMOs are run by private insurance companies. They offer Medicare Advantage programs. You opt into Medicare Advantage, and you give up traditional Medicare. So it is an absorbing state. You can't switch between them. And there are some differences across the Medicare Advantage programs, and especially between traditional Medicare and Medicare Advantage, right? One of the, namely being that it's an HMO, right? It'll have lower premiums typically. Medicare Advantage has lower premiums than traditional Medicare by and large, but it often offers less insurance, right? In the sense that traditional Medicare does not have a lifetime spending cap. Many Medicare Advantage HMO programs do, right? There's a lifetime spending cap. Excellent. Okay, so there's differences. But we went through this experiment, and this is still ongoing. People are on Medicare Advantage. And a few years into introducing Medicare Advantage and introducing HMOs into Medicare, they ran the numbers. And they found, in fact, that retirees who were insured through Medicare Advantage programs had lower average spending costs than people in traditional Medicare. And some people declared victory and said, look, HMOs bring down the cost of Medicare, right? And they may be doing so. But that difference in average spending is only, is obfuscating differences in actual sort of ability to save money on healthcare and selection, right? So I want to illustrate the selection problem with an example. This is out of your textbook, but I want to go through it very carefully. So let's first look over here in this leftmost column. This is traditional Medicare before we introduce Medicare Advantage. So in this population of people, we have three kinds of people. People who are pretty healthy, people who are kind of sick, and people who are very sick. So the first group of people have average spending of $1,000. The middle group is 100 people who have an average spending of $2,000. The third group are a bunch of 100 people who spend $3,000 each. So what is the total cost of Medicare here? Well, on average, it's $2,000, right? Total for this group of people, it's going to be $600,000. It's going to be 1,000 times 100 plus 100 times 2,000 plus 100 times 3,000 is $600,000. Then we introduce Medicare Advantage. And we see people, they say, oh, look, there's this new program. They look at the details, and they decide whether or not to opt into Medicare Advantage or to stick with traditional Medicare. Who do we know is most inclined to switch into an HMO? The healthier, right? So let's imagine that's in fact what we saw. So of the 100 people who are sort of the healthier group, we see 70 sticking with traditional Medicare and 30 going into Medicare Advantage. The sort of medium health group, we see 85 sticking with traditional Medicare and 15 going into Medicare Advantage. And of our super high spending group, they look at that HMO and they say, no, I really need to see my 4 specialists once a week. I can't really switch over to the HMO. It's going to be too hard for me with my medical needs to deal with all the paperwork of an HMO, the hassle of an HMO, so I'm going to stick with traditional Medicare. So what has happened to the population of people who have remained on traditional Medicare? Are they sicker on average or healthier on average? They're sicker on average. They're higher spending on average, right? The people who opted into the Medicare Advantage program are healthier on average. So when we look at average spending across these groups, there's a huge difference, right? It's a difference of roughly $2,100 versus $1,300, right? And you can look at these numbers and say, look, Medicare Advantage has brought down spending. But the question is, who are they treating? Are they treating people who cost less anyway? And that's in fact what we found, that they're treating people who cost less anyway. Maybe they're saving money on those people somehow too, but they're by and large just treating a healthier population of old people. So the total cost of government now is in fact $630,000, $631,000 almost. And why is that? It's because we've agreed to compensate Medicare Advantage providers at the average spending of traditional Medicare. So even though they have sort of cream skimmed and are serving a healthier population, we're compensating as if they're serving the average person who stayed on traditional Medicare. The average person staying in traditional Medicare actually now costs more than the average person used to before we introduced this program, because we have a sicker population on traditional Medicare. So we're paying $2,100, right, $2,118 per person covered on Medicare Advantage, but the cost of each person on Medicare Advantage is only $1,333. And that's because we didn't think about selection when we set up this system. Or we didn't act like we thought about selection when we set up this system. Is this clear to everyone what happened here? What's going on? Yeah. Okay. So, I mean, there might be some victory to be declared from the HMO system. They might be holding down costs, but it's very hard to separate that from the fact that they're just treating healthier people. Yeah. Question?
The average cost for HMO enrollees is the same as the Medicare,
Oh no, so per in the HMO they're only spending $1,333 per enrollee.
right? But when they multiply the per person average cost,
Yes.
it's the same like that.
Right, because this is what we're compensating the HMO providers. So that's what the government is giving them for covering Medicare people. Then we're giving them whatever we spend on average in traditional Medicare, right? But the average spending on traditional Medicare has gone up because we're treating sicker people. And so even though they're treating healthier people than traditional Medicare, we're giving them the same average spending. That's even higher than the original program. Does that make sense now? Yeah, okay. Okay, so now let's talk about healthcare reform. I know you've been waiting for it all night. Okay, so when we designed a healthcare reform initiative, whenever we've talked about a healthcare reform initiative, starting back in the day, right? The goals have always been universal coverage, right, even a long time ago. But starting in the 70s, one of the goals became sort of slowing the rising cost of medical care. So universal coverage and controlling the rising cost of health care. So why are healthcare costs rising so rapidly? Right, this is a question, right? They're rising much faster than GDP growth, faster than other parts of the economy. It's been they've been growing at a very fast clip. So part of this has been that a lot of healthcare technology, things that have been invented to improve health outcomes, have been cost increasing. They've just brought, we're better at diagnosing stuff than ever before, but it's expensive to do so. It's just cost increasing. Competitive markets encourage new and costly technologies, right? The fact that people are out there waiting to, there's Medicare, there's a group of old people willing to, there's coverage, there's insured populations at all ages. There's a market for medical care. And firms that are in the innovation business are going to innovate products to serve that community, right? And we sort of see new technologies. And they're great technologies, but they are costly technologies. And there are cost-saving innovations that have been created too. So ways that, we can sort of diagnose a disease earlier. But like I said before, while it's cost-saving for those who would one day go on to get the catastrophic illness, the wide sort of availability of the low-cost sort of diagnosis technology or some kind of healthcare provision makes average costs go up, right? Because this innovation saves us a lot of money per person who actually gets that horrible illness, but we're giving a lot of people who never develop that illness access to that technology. And so average total, or just total spending is going to rise. So, okay, and another reason why healthcare tends to rise faster than the rest of the economy is sort of in most parts of spending, we think about marginal benefit versus marginal cost, right? When I think about whether I should want to go see The Cabin in the Woods, I think I'll kind of probably enjoy it to some degree, and I then think about the price of the movie ticket, and I decide whether or not it's worth it to me to go see The Cabin in the Woods. Lots of things are like that, right? Movies are like that. Even lots of things government does is like that, right? Whether or not to sort of create a new college tuition support program, we think about the marginal benefits and the marginal costs. But medical care is provided by licensed physicians who, through their schooling, are taught to provide health care until a person no longer benefits from health care, right? That if a treatment would make someone healthier, it is worth providing, right? As part of their code of conduct. It's a profession that has its own ethics. The ethics of medicine sort of make a physician inclined to provide care as long as the marginal benefit is greater than zero, regardless of whether it's higher or lower than the marginal cost, right? And those are the folks, the supply side is part of what determines equilibrium, right? The equilibrium level of medical care. So doctors are trained to provide medical care until marginal benefit is 0. But economic efficiency says stop sooner than that. Stop when marginal benefit equals marginal cost. It's a difficult part of this question, right? That when we think of people being sick, we want to provide them with care. And the idea of stopping sooner than they would no longer benefit from care is controversial. But I think it is worth remembering, to some degree, that large parts of government use, whether the marginal benefit is greater than the marginal cost. Sure, stuff like environmental standards, right? Environmental standards, determine, asthma rates and whether kids have asthma. I mean, there are health implications to environmental standards, right? We think about marginal benefit, marginal cost there. We think about regulation. In education, we make this decision often, right? And education changes people's quality of life, right? We think about marginal benefit and marginal cost. In housing, we do so, right? Whether or not we provide housing to people or how we support them as they seek housing changes lives too. And we have a cost sort of constraint in mind. Even road safety, right? Road safety is about lives. It's about lives. Lives saved and safety and health. And we think about marginal cost when we think about road safety. Medical care is one of the few places it is sort of the place we don't. We provide until marginal benefit equals 0. I do want to say one thing, about marginal. So I talked about the flat of the curve medicine. You could imagine the curve could in fact turn downward eventually, right? There could be a provision of medical care that actually hurts health. One of the causes of that is that, just there's a risk of when you enter a hospital of catching something. There are these sort of scary bacteria, and we hear every year that 50,000 deaths are caused by, hospital stays, right? So there is some sort of underlying risk of being admitted to a hospital, of catching something else. There's also, medical care, unlike I said cars, and you get some utility out of even your 100th car, right? A lot of medical care has no, experiential utility, right? There's no one enjoys our open heart surgery or the recovery associated with that. So you can imagine on net for people, too much medical care could really be negative at some point. Okay, so achieving universal coverage. We've talked a little bit about this before, right? We talked about pooling and separating equilibria. If we're trying to get everyone into the big pool, right? You're forcing people to pool. There's 2 ways to do it. You can try to, you're gonna make it compulsory, right, for them to be part of the pool. You're gonna mandate that they be part of the pool, compulsion. But some people can't afford to be part of the pool, right? They simply don't have the income to cover their premiums. So if you're gonna force people to jump into the pool, you're likely gonna have to have some subsidies as well. You could also try to just use subsidies alone to try to make insurance more attractive to more people so that they jump into the pool. But eventually, if you really want everyone in, you're gonna have to make it mandatory. Ways to achieve universal coverage? What we have, right, is a mandate. That's what the ACA does. It's a mandate at the individual and employer level. You could also not force people to go out and buy insurance, but just say, you woke up, you were born, you're part of the insurance scheme. We're going to tax you, and you're going to be insured. Medicare works that way, right? You work, you pay taxes, you're covered. There's no one tells you to go buy Medicare insurance, old age health insurance. You're just part of the insurance scheme. And that would be more like a universal single payer system would have that feel. Okay, this is the last slide, and then we'll get on to our discussion. The Affordable Care Act, what does it do? And what is it? Well, it actually encourages cost-benefit analysis. It's been controversial at times. There's provider payments are a change. So there is this effort to link payments to long-term outcomes, to what's happening to your patients. It also encourages integrated health systems and the bundling of payments. So they want your doctor and your hospital, and the vertical integration of medical care is something it encourages. So people are looking at, not necessarily all one company, but more that your health records are integrated, care is integrated, your doctor knows exactly how you were treated at the hospital, right? And sort of he's also held liable for doing the right thing as follow-up, right? So it's sort of trying to create incentives for providers to look at long-term health outcomes. It has, of course, the individual mandate. It also has an employer mandate, which we talked about. It has the exchanges, which help small businesses. It has provisions for very high-risk individuals. You can be pooled into sort of groups that, and it helps subsidize premiums for people who have very high healthcare risks. There are subsidies for low-income folks who can't afford the premiums that they're being mandated to purchase. And the final part of it is it's unclear right now if it's constitutional, whether the mandate part is constitutional. And that's what's going through the courts now, and sort of we're waiting to see what happens with that.